We are all set to go.
Thank you, Soma. Namaste all. Um, I'm pleased and honored to moderate today's webinar session on how to conduct a root cause analysis. I welcome you all for this webinar session. There have been people joined in this Zoom call, and it has also been live telecast on the YouTube. So I welcome you all. Just allow me to share my presentation. I'm Balaji, and I'm the Senior General Manager and Regional Head, Managing Quality at Apollo Hospital Southern Region.
Good morning.
This webinar has been conducted as part of the International Patient Safety Conference pre-conference event, and today is the 9th webinar. And all the previous 8 webinars have been received with so much support and welcome by all the healthcare professionals. Thank you for that. This conference is been scheduled. The International Patient Safety Conference, the 9th season, has been scheduled on 13th and 14th of February at New Delhi. The registrations are, there. I request everybody to immediately book your registrations. There are some interesting events in the conferences. It's been attended by international, speakers, international organizations. We have got over already over 800 delegates registered for this conference. It's one of the happening conferences in the country. So please do book your slots for this conference. Before going on to today's session, I have few house rules. I request everybody, all the participants, to keep your audio on mute. I also request to have no video, please, because it might be a distraction. We also request you to not to clutter the chat box. Please do. We'll be having the question and answer sessions at the end of the webinar session. So definitely the speaker is going to address all your queries. And there won't be any certificates for the session. And you have to. So tomorrow is going to be the last webinar in the series, and you have to register separately for that webinar. Those are the instructions. So today's session is on how to conduct root cause analysis. As a healthcare professionals working in hospitals, we all have many challenges on a day-to-day basis. When we come to our work area, we have a lot of incidences being reported, hazardous condition, near-miss events, patient safety events, sentinel events. There are many such things reported. And what we all try to do is to define the problem, understand, treat the symptoms that we see on the surface, and and try to come out with some solution. But what happens is that eventually that it gets repeated. The same incidents do happen. And whenever we try to do submit this report, we always get a remark that all our corrective and preventive action ends up with training and education. So this has always been commented. So fixing the symptoms is just part of solving the problem. It is not completely the solution. We have to understand the deeper causes, and that's what we are going to hear to today. Root cause analysis is a part of the total quality management, and it includes number of problem analysis, problem solving methods, and root cause is one among that. To discuss about this on how to conduct root cause analysis, we have a very eminent speaker. We have Dr. Catherine Leonhardt. She's a principal consultant for quality and patient safety for Joint Commission International. We welcome Dr. Catherine for today's program. Through the JCI quality programs, Dr. Leonhardt has expanded the education and training for over 3,300 healthcare professionals in over 40 countries. Dr. Leonhardt is a preventive medicine and public health physician with over 30 years of experience in leadership positions in public, private, and academic healthcare settings. She has conducted research, published, and taught in the areas of quality, patient safety, and patient experience. Her research and publications have included epidemiological investigations, drug trial, phase 3 clinical trials, and quality improvement projects. And she has done it for AHRQ quality funded projects on patient advisory councils. She has a bachelor degree from Williams College, a medical degree from University of Michigan, a master's in public health and epidemiology from the University of California, Berkeley. And she is a certified professional in healthcare quality, CPHQ, CPPS, which is certified professional in patient safety. She is also a Team Steps master trainer and Six Sigma Green Belt. What an eminent personality to discuss about root cause analysis. We are extremely honored and privileged to have her here. And Dr. Catherine, we are so pleased that we could have you for this webinar session and you could address everybody. Thank you for accepting, and over to you.
Thank you, Balaji. Really appreciate the introduction and welcome. I'm really excited to be here. I have heard so much about Apollo, and it's great to be part of this amazing webinar and conference that's been going on for years, and the great work that you're doing to share some of the lessons learned around the globe. So let's dig into root cause analysis. As Balaji introduced, we are confronted consistently with patient safety challenges around the globe. In fact, the research indicates that 1 out of 10 individuals who are hospitalized around the globe will experience harm. And unfortunately, over the past couple of years with the pandemic, this rate has increased. So the field of patient safety, we've adopted methods and tools from other industries who have been studying safety and accidents for longer than we have in healthcare. And root cause analysis is actually an engineering tool. So I want to share with you over the next hour some tools, some methods. We're going to use a case study to help review some of the fundamentals of how you should be conducting a root cause analysis. So from this webinar, you're going to gain insight and be able to define what is a root cause analysis, identify what we talk about as 4 phases or 4 steps of conducting the analysis, and understand how you can prepare your organization and your safety program so that you can make these even more effective. So let's do a quick knowledge check before we dig into the content here. What is the purpose of a root cause analysis? So if you'll add in the chat your answer, is it number 1, to identify the staff who made an error? Is it number 2, to improve gaps in the systems that contribute to the event? Or is it 3, to complete your fishbone? Go ahead and add in the chat and just drop in 1, 2, 3, whatever number you think it is, because many of us come to this with different backgrounds, different experience with using the root cause analysis or the RCA tools. And I'm following the chat and I see a lot of 2s coming up. So that really is the correct answer. When we think about a root cause analysis, it's always important to focus not on the who, but on the what and the why. Understanding those gaps in your processes, your systems that led to that undesired outcome, such as harm, right? It's understanding that it's not just staff who need more training. As Balaji noted, many of our corrective actions lead towards that. It's identify how we can fix those systems and processes so staff can't make a mistake, or so staff are always led in the right direction to do their work without any variation. So I know many of us equate RCA with this fishbone diagram, and there's 2 important points about that. It is a tool, but it's only one of many tools that can be used as part of your RCA. And I'm going to introduce a few more that can be used and should be used. And the other important point of this is that the tools themselves are not important. Tools are just mechanisms to collect and organize your data. More important is the framework, the concept, and the purpose and goal of the root cause analysis. That's how we use the data, how we interpret the data. So, yes, we often use a fishbone. It's a great tool. More importantly, think about the construct and the concept, the principles behind the root cause analysis. And that's what I want to emphasize. So, what is a root cause analysis? Well, I'm going to clear our screen here if I can. There we go. A root cause analysis, a better definition, is really a comprehensive systematic analysis, because that's the intent of it. We're looking at identifying those causes that may lead to variation from our performance expectation. Let's think about that definition. It talks about this analysis of the entire system, a comprehensive systematic analysis, more than one system, right? Because we know healthcare is complex and there's multiple systems at play, even when we're talking about one process or one event. And we're trying to identify that variation or deviation from our norm, what our standard is. It may be variation in the process. It may be variation in following the process that leads to that unexpected goal, what we want for the patient, which of course is no harm. So RCA, the term, actually is misleading because it implies that there is one root cause. It's a single, not plural. And we know, in fact, from research in healthcare, there are usually up to 4 or 5 root causes that contribute to the event. The term also implies a linear relationship. One cause leads to the one event. But we know those root causes are often interrelated. There's a complex relationship between the factors. So I prefer the term comprehensive systematic analysis. And it's important to consider what the purpose of this is. It seeks to answer the questions in this order. What happened? Why did it happen? How can it be prevented from happening again? And how will we know if our actions or interventions worked? Right? So an RCA is used when we want to answer the question, what is causing us to miss our performance goals? And in fact, we use the same tools that we use when we're working on a quality improvement project, focusing on the systems and the process, less on who did it. So around the globe, many of us are familiar with or trained in the RCA. And that's why I use that title for this webinar. Again, the correct term, more broad term, is this comprehensive systematic analysis. And there are other models out there besides the root cause analysis. Some of you may be familiar with the London Protocol, the Tuscan model, PRISMA. But root cause analysis, RCA, is the method that I was trained in, that Joint Commission primarily references. So that's what we're going to be focusing on today. And note that it really is the method that's used to address those harm, sentinel events, patient safety events that we need to do a full review. Often takes weeks up to months to review and complete the analysis and develop our action plans. That's the focus of today. But there are lots of types of analysis methods. And you see on this slide on the left side that I've listed some of those. You may use a method for analyzing safety events or hazardous conditions that is different from the root cause analysis. Some of these listed here, common cause analysis or aggregate review. Those are done for analyzing groups of similar events. And you see on the right side of this slide some examples. Maybe you're having a frequent blood transfusion reactions. And you want to understand what is this trend or pattern that we're having. Is there some common cause that's leading to this? In the JCI standards, we require something called an intense analysis, which may fit into this area when we see a trend or a pattern in undesired outcomes. The concise incident analysis or apparent cause analysis is a limited investigation for those events that may not result in harm or minimal harm or a near miss, right? And these are usually due from some obvious mistake or failure in the system. So they don't require the intense analysis that's required for something like a more significant pattern or trend, or of course, a sentinel event. And then at the bottom of our list of types of events, our pyramid of events is at hazardous conditions. And those are things where nothing bad has happened to a patient yet, but we know there's a high risk. And those are things that we often use at proactive risk analysis, failure modes and effect analysis. What could happen? So it's important looking at this slide that you understand there are different methods for analyzing patient safety events that you would apply depending on the type of event and, of course, depending on your training. You're not going to learn how to do an RCA in 1 hour, but I encourage you to select 1, 2 of these methods and train, do some more research, do some more understanding and learnings to really solidify your skill set in using these tools and methods. So here's a 4-phase approach that I teach in my quality training program. This 4-phase approach is consistent with the Joint Commission framework. And in fact, we have a wonderful publication from Joint Commission that provides even more detail on these 4 phases and breaks it into actually 21 steps. But this is a simple framework for you to consider, for you to be able to follow as you're doing your root cause analysis. Now, it's important when we think about a root cause analysis, it must be thorough and credible. And those 2 terms are used in our standard around the RCA. Thorough means you have a detailed description of the incident, you identify those contributing factors and develop those actions to improve. Credible is that you have full participation from your team, your leadership. You're looking at the most current evidence-based, the literature and other information, not only on how you conduct the RCA, but what your actions and improvement solutions are going to be. Important point on this slide is that you follow these phases in sequence deliberately. You must start at the beginning, phase 1 and 2, because those focus on what happened, where it happened, when it happened, how it happened, before you get to the why, which is our phase 3, understanding why, what were those causes that led to it. And then, of course, phase 4 is implementing those corrective actions. So we're going to walk through this fairly quickly and just highlight the key components of each of these phases. Well, the best way to learn how to do an RCA is to do one. So I'm sharing with you a summary of a case study that we use when we teach root cause analysis in our workshop, which is a much longer than a 1-hour webinar. So let's imagine that you're responsible for leading the root cause analysis on this case. This is the case that we're going to use is a 34-year-old female with leukemia being treated with 2 chemotherapeutic agents, vincristine and methotrexate. On the day of her scheduled infusion, there's a new physician, an oncologist, that's starting his very first day in the health facility. He has not even completed all his orientation. He's working under the proctorship of a senior consultant. But this senior consultant has a family emergency on that day and has to leave the hospital. Well, this patient arrives and the new physician is available to take care of her, administer her chemo agents. But when that patient arrives into the clinic, there's some chaos. Another patient in the clinic has a cardiac arrest, and the nurses are occupied with this emergency. But the 34-year-old patient is waiting for her chemo. So the oncologist asks one of the trainees, a resident on duty, to help assist him. They collect the medications, the patient's prepped, and the oncologist administers the vincristine intrathecally. Now, for those of you who may not know, vincristine is intended only for intravenous administration. When vincristine is administered intrathecally, it leads to significant complications, paralysis, and usually death. So this is our case that we're going to use. And I want you to be thinking about this and think about some of the things that happen, some of the situation that led to this event. Well, the first thing you need to do is prepare. Phase one is really getting ready, setting the stage for how you're going to conduct your RCA. You need to get a team. Well, some healthcare facilities create a team for every event. Event like that happened, let's pull together a root cause analysis team. That's great, and you identify those that you think should be part of that team. Other organizations have a regularly scheduled, a set RCA team. The membership doesn't vary, right? They may add some ad hoc members, but they have a core team who are trained, who are experienced, who have it on their calendar. For example, every Tuesday at 7 a.m. And if there's not an RCA to be done, they can cancel that meeting. You decide how you want to do that. I like the established membership, established team, because we know those people have that training and experience, and they're always ready to evaluate and conduct the analysis. The team size ideally should be less than 10. In fact, the ideal team size for any project is 6 to 7. But make sure you have the right people. You need to have an expert who can conduct the RCA, right? Someone who's skilled and trained in the tools and the methodology and the concepts. You need to have a human factors specialist. We're going to talk about that a little bit. That the principles of human factors are most critical in our approach to patient safety. You need some type of leader. Sometimes that's a formal leader, like the chief medical officer, even the chief executive officer. And you need those frontline staff. Your RCA team should not be all managers and senior leaders. You need people who are at the bedside, people who are doing the work. They are the experts, right? And there should be physicians on your team. They're part of the care team. There are some strategies for running an effective meeting, setting the stage so staff are comfortable, having a standard protocol and sequence in your agenda, right? A really great tool for setting the stage for open communication is saying we're all going to use first names, not have senior members, that authority gradient kind of make people uncomfortable. Maybe the leaders share an experience when she or he has been part of a team that led to an adverse event, creating that openness. You need to define the problem then with a simple statement. This is often where people get caught up right away. This is focusing on the facts, avoiding assumptions, just stating what is the problem. And then gather information. You may interview some of the staff involved in the event. In our case study, maybe the nurses in the clinic, the physician involved with administering the chemo. You may collect some evidence, maybe some materials or equipment that were used, or review some documents. medical records, policies and procedures, things that will help you better understand what happened so that eventually we'll get to why. So, how would you define the problem in the event, the case study that I just described? Think about how you would define that problem. So here's the summary problem statement from a team who analyzed this event. 34-year-old female oncology patient administered vincristine intrathecally. That is the statement. That is the problem. It doesn't say staff didn't follow policies or physician wasn't oriented or resident was helping when he shouldn't have been. It avoids assumptions or reflections and considerations about why it happened. You start with what happened. Start at the very beginning. Again, you need to know what happened before you can determine why. So phase 2 is still focusing on, let's use some tools to understand what really happened here. One of my favorite tools, of course, is a process map or a flow chart indicated at the top. Create a simple flow chart of the process. There may be multiple processes involved here, right? But create a simple flow chart for those processes. And looking at that, analyzing already your flow chart, starting to help you set up understanding why, you're going to consider some things. Are there some risk points in that flow chart? Some risks in terms of specific process steps or links between two of the process steps? Is this process flawed? Is this just a bad process? Or did the staff not follow this process? Was there a gap in the staff following our standard operating procedures? The second tool that I really like is shown here. It's a change analysis worksheet. That's what our Joint Commission tool is that we have in one of our publications, also called a comparative timeline. You may have a different tool. The important point here is that you create a very detailed timeline of the event. And I like this table shown here. It's just a section of the worksheet, abstracted and shown on this slide. The first column is you're going to identify the date and the time when the events happen. And note, this may take place over a long period of time, a day, maybe a couple days. So keep track, and as specifically as you can, maybe by hour, if you have documentation, by minute when things happened. And then the second column is what happened. We call that work as done. What actually took place? Think about that event that I shared with you, the case study. What were the actual steps that took place and at each timeline? Then the third column is what should have happened. We call that work as planned or work as imagined. One of our patient safety experts, Hallnagel, used this concept in his research, looking at work as done as compared to work as imagined. We all know we have policies and procedures that define what should have happened. Things like hand hygiene policies that tell us the 5 moments when we should wash our hands, but do we always wash our hands at those moments, right? Understanding that what happens, work as done, is not always the same as work as planned. And then identify the differences, the gaps between those two. We're starting to set ourselves up with this very detailed description of what happened so that we can dig into, and why did we have that gap in performance? Why did the staff not follow that policy and procedure, right? And it's important that you take this timeline and you look at each one of those steps. So thinking back to our case study, what happened? Physicians started working in the clinic. What should have happened, work as planned, that physician should have been completed his orientation and training. What happened? The new oncologist was practicing alone. What should have happened is that senior physician, senior consultant was there to help proctor and mentor him. Why was there a gap between what happened and what should have happened? We don't know. That's where we're going to get into the why did that happen? Okay. So this is a frequent failure of RCAs. The team does not take the time to understand the details of what happened. We tend to jump right to why it happened before we do this. And what you're doing is you're missing some of those opportunities to understand root causes, opportunities to understand the details behind what happened, that you're going to miss out on being able to develop a better process or provide some defenses, barriers, so that staff can't make that mistake or that mistake doesn't reach the patient. So encourage you to look at these tools. Most of us know process maps. Some of us have been trained in a tool like a change analysis worksheet. Many of us have done timelines. Take it to that next level. Right? So after you've figured out what happened, now we can get to the why. This is when you start diagnosing, right? Understanding what are the causes that led to that event. Digging deeper. Well, I like this diagram. Comes from a recent publication just a couple of years ago that is similar to our iceberg concept, put on its side, if you will. So to the right is the incident or the tip of the iceberg, right? But with icebergs, we know that only 10% of the mass is above water. The rest of it is hiding underwater, as reflected here on the left side of this diagram. The problem we see is just a small part of it. The real problem hides under the surface. So though we focus on the incident, we know we need to look at that huge underlying contribution to what led to the problem. So if we start with the incident and then we start working our way right to left, we see some defenses or barriers, those green blocks on the slide. But these are these interventions that help separate us as humans, the staff, from the error that we might make from actually reaching the patient. These are these last defenses that we often put in place that help any type of error that we as humans may make reaching that patient. Examples of these are when we have two staff do a double check, independently check a medication. Think back on our case study. Or if we only allow certain catheters and syringes to connect to certain tubing, some mechanism that we can't make, that mistake cannot reach the patient. Those are important concepts to be thinking about as we're building up to our action plans. The next column, moving further to the left of what was called the care delivery problems. This is the human performance of delivering care, right? This is the staff actually performing the work. And why I like this diagram is those staff performing the work, they're often described as 3 behaviors that lead to human error. Some of us have been trained in the concept of just culture, where we think about the 3 types of behaviors or performance in our job that describes the type of errors that humans make. One of them at the top is what we call unsafe acts or at-risk behaviors. That's when the staff drift away from what we know we're supposed to do. Again, think about hand hygiene compliance. Do you know the hand hygiene compliance globally is around 60%. We all know, we've all been trained. I don't need more training to remind me to wash my hands when I'm supposed to. But we drift away. We have this at-risk behavior because that may be the norm. That may be the cultural accepted rate of hand hygiene compliance. It is. It is. We've consistently studied this around the globe. But humans also, in the middle commit simple errors, mistakes. We call them mistakes or slips or lapses. This is inadvertently making it a decision, or perhaps picking the wrong medication to administer, like in our case study. These are things that we as humans make. And that last type of human behavior, error behavior, called violations, those intentional acts, are very rare. When a staff intends to disregard the risk, or maybe intends to even cause harm to a patient, very, very rare. But that is one of the behaviors that we have to consider when we're analyzing and investigating our events. So when we think about the care delivery problems, that's the human behavior. Always remember there are different types of reasons why we as humans, your staff, may make a mistake. And I like considering the three categories: unsafe, errors, and violations. But then we keep going deeper in this iceberg, if you will, and let's think about those contributing factors. Those are these categories of factors that have been identified through research in healthcare that commonly influence staff who are delivering that care. They may not directly cause the event, but they set the stage. So in our case study, one of the contributing factors was the workplace environment. There was chaos. There was another patient having a code. Staff had to leave, which impacted, of course, the team factors. And then we go further, even deeper yet in this iceberg, understanding those organizational, cultural factors, what we call those latent factors or root causes that are underlying, influencing how the environment is, how the staff interact. They set those cultural norms that allow a physician who hasn't completed their orientation, who no longer has a senior consultant mentoring him, to deliver a very high-risk medication in an environment that is chaotic. So this tool helps you kind of think about that iceberg image that many of us were trained on, but it helps really kind of expand on those. So this single diagram can be used as part of your RCA process as you're helping frame how you want the team to be thinking. Not just, let's do your fishbone, but let's think about all of these underlying factors. And here we are, phase 3, and now we're finally at that fishbone, right? At this point, you may use the cause and effect diagram or the Ishikawa diagram or the fishbone, however you like to use the name. And all of this is, again, is a brainstorming, a tool to help brainstorm, to help identify those possible causes of a problem and sorting them into categories. And we use this, of course, as it kind of looks like a fish with a problem statement should be at the head of the fish, right? And then the categories you decide. Many of us were trained in the 4 or the 6 M's that are shown here on this slide. These actually came from manufacturing. There's also 4 P's that came from the service industry. But you decide what are the categories, and then you brainstorm with your team, what are all the different potential factors that could have led to that outcome. Then once you've got those causes, you may apply a second tool called the 5 whys. And you see this on the diagram, asking, but why did that physician start working in the hospital without completing their orientation? Why did he not have a senior consultant available? Right? So you start asking what we call the 5 whys. It may be 3, it may be 6 times that you ask that why. The intent is you're trying to break down, dig deeper into those causes so that you can understand, was there some underlying contributing factor? And was there even a latent or organizational factor that influenced why that environment was chaotic or influenced why that physician didn't complete his orientation? Is the culture such that they allow that that's acceptable? So using the fishbone and the 5 whys helps you get to a underlying contributing factor, system latent factor that's not a person, it's a system or it's a process that is impacting how that staff does their job. And one of the key things is as you're doing this and trying to dig deeper, is you need to find a cause that's actionable, right? Getting to that root cause, that process or system that you have some agency over which you can influence. For example, some of us get to a root cause and say, we need to hire more staff. Well, if you happen to be the CEO or a senior leader and can hire more staff, that's great. But especially in this day and age, it's really hard to do that. So get to a underlying cause that you have some ability, some agency, authority to impact. So here's an example from one of our teams that evaluated the case study, looking at some of those contributing factors and some of those latent factors. In this organization, the culture was one that it accepted the disregard for policies and procedures. Their culture, though they had several policies and procedures about, double checking chemo agents and making sure staff complete their orientation before they start performing clinical care. But their culture accepted, that doesn't, we do that most of the time. It's okay if someone wants to ignore some of those policies. They had some equipment factors where they had some of the medications stored in the same place. They had some team factors around a hierarchy. That the authority agreement where a senior member could leave the hospital and tell the other staff, it's okay for me to leave, let that doctor practice without me here. And everyone said, well, she's a senior consultant, we'll listen to her, we don't want to argue against her. So understanding some of these factors helps you address and develop your action plans. So phase 1 and 2, we talked about identifying what happened. Phase 3, figuring out why it happened. Phase 4, we're going to talk about how can we prevent this from happening again. So as we get to phase 4, simple question, another knowledge check. Please put the answer in the chat. The goal of patient safety, I might say the goal of our action plans during phase 4 is to eliminate error. 1 true, 2 false. Go ahead and just drop your answer. So think about our goal of our action plans of what we're going to do here. The whole goal of patient safety, right? Okay, I see a lot of truths. I think all of you have said 1 is true. I hate to tell you this, but the correct answer is false. The goal of safety is not to eliminate error, because remember, to err is human. To err is human. In fact, the best quote from James Reason, who created and was a psychologist in the UK who created the concept of the fishbone of the Swiss cheese model and did a lot of the research on studying accidents to help us learn from the science of safety. James Reason's quote is that human error is a consequence, not a cause. Errors are inevitable. We as humans, to err is human, right? But errors are really the byproducts or the symptoms stemming from those underlying, those upstream problems, the organizational culture, the contributing factors like teamwork. Identifying an error is only the beginning of the search for causes, not the end. You cannot fix the human condition. To err is human. You can fix the workplace around you. How do we prevent harm from happening again? Is not that we're going to prevent humans from making an error. We're going to adjust the processes, the environment, the equipment around us. We're going to fix our systems so that we're going to make it easy to do the right thing and hard to do the wrong thing. Think about that. Create your equipment, your processes, your systems, so it's easy to always pick the right medication. It's hard to administer the wrong one, right? How do we do that? We put in these solutions, actions, interventions, whatever term you like to use. And the rule of thumb, if you will, is stronger actions are better than weaker actions. And stronger actions, as indicated in the top 3 rows, are those types of actions or solutions that have less reliance on humans. Things like physical forcing functions, engineering controls. The example we use is you can't connect certain IV tubes with different catheters, with different syringes. The physical connection doesn't work. When we talk about fire doors, those prevent, they are made in such a way that the fire can't get through those doors, right? It doesn't rely on the human to do something. It's a physical engineering and equipment change that makes it really hard to do the wrong thing. Now, some of those weaker actions are ones that we still may do, but they rely on us as humans. And everyone's favorite corrective action after a root cause analysis is training. And you can see it's one of those weaker actions. Now, when you think about training in this case study that we talked about, do you think a oncologist, even though he's new in that hospital, do you think he hasn't been trained about vincristine? That is kind of a known, huge, high risk around vincristine. Do not give it intrathecally. He's had training. He knows. He doesn't need more education on that medication. What he needed was some type of forcing function that wouldn't allow him to make that simple mistake, that error, right? And some of those intermediate actions are things that we talked about with having maybe 2 staff calculating the med dose or reviewing it. So think about this when you put your corrective actions in place for your root cause analysis. Lean towards those stronger actions, right? Not just those things that rely on us as humans, because to err is human. We will never eliminate errors. We can make it easier to do the right thing, make it harder for us to make a mistake. Or if you remember my diagram with those green barriers, have some last minute barriers, defenses to help prevent that error from reaching the patient. So how do we prevent it from happening again? I talked about engineering controls. Well, one of the most critical concepts in patient safety that we've learned about in the past few years is human factors. Human factors is understanding the interaction, the relationship between humans and the systems within which they interact. It's understanding how we as humans process information, how we're influenced by our environment, and that may be things like noise or light or chaos, but it's also how we're influenced by the culture, the organizational norms, right? How we interact with the technology around us. Applying human factors is a critical concept that you need to incorporate in your root cause analysis. And it will help you think about corrective actions that are more aligned with not eliminating error, but making it easy to do the right thing. So this diagram I'm showing you here is on the left side, it shows you the tubing for the oxygen and the nitrous oxide are right next to each other, the receptacles in the wall. And unfortunately, several years back, there was in one operating theater, there are 2 patients that died because they mixed those hoses up. They plugged them into the wrong receptacle. Well, if you look on the right, it makes it really hard to make a mistake now because the receptacles, the plugs, are at different angles. If you can see carefully in that picture, you can't plug the nitrous into the oxygen or the oxygen into the nitrous, the hoses, because the receptacle and the plugs are configured differently. It makes it really hard to do the wrong thing. Even if you're in a chaotic situation, you need oxygen and you go to plug it in the wall and you didn't read that that's a nitrous, you can't put it in there. That's what we talk about, those forcing functions. In a lean language, you call it poka-yoke or mistake proofing. So what would be an engineering function or a forcing function that might be used for their case study? How could we prevent that vincristine from being administered intrathecally? Well, I'll show you. In fact, there's a Joint Commission Sentinel event alert that was published several years ago that talked about this. You should pre-mix your vincristine in mini bags. This makes it really hard. An oncologist is not going to administer the vincristine through a mini bag. He's going to say, oh my gosh, yes, this is an IV for IV administration only. It prevents that mistake from reaching the patient. So part of your assuring you have actions to prevent things from happening again is using data and monitoring it. This is really just part of your sequence of an improvement project. Whatever method you use, Lean, Six Sigma, PDSA, doesn't matter. You're at this point, once you've identified your corrective action, is test them. Before you implement it across your organization, let's test it and collect data and monitor, right? So the best tool to use for this phase is a control chart. You monitor your results. You can see, do we have consistency? Is this practice now stable, right? So I encourage you to be familiar with control charts, to use them even as part of your control, as part of your corrective action with your RCA. Ongoing monitoring to make sure that you sustain those improvements. So we've reviewed the 4 phases. You've heard about some tools, some that you probably are familiar with, the process map, comparative timeline, the fishbone and 5 whys and control chart. But all those tools, the RCA approach is irrelevant if you don't have an organization that supports that open, transparent approach to reporting adverse events, analyzing them, using data and to drive your improvement. So this slide just gives you a list of some of the critical elements, what I call prerequisites for an incident management program, for an RCA to be effective. These are the building blocks that must be in place for any organization to have an effective root cause analysis. So, as I said earlier, you're not going to learn how to do an RCA in 1 hour. We have lots of resources through JCI. This is a picture of our root cause analysis framework. It's a template that you can use with prompts and areas for you to document the answers, the findings from your analysis. We provide workshops, virtual or in person. In fact, we're going to be having a couple more. We've actually taught over 1,000 individuals through our root cause analysis workshop in the past couple of years. As you see on the right, there's a root cause analysis in healthcare publication from Joint Commission. You've got some great publications that are, and this one is in its 7th edition. So I encourage you to continue to learn, to expand your knowledge, to participate in root cause analysis. That's the best way to learn. So in conclusion, an RCA should be conducted using an evidence-based approach, focusing on the systems and processes, not on finding who is at fault, who we're going to blame. And remember, you cannot change the human condition. To err is human, but you can change the conditions within which we work. Thanks so much for the opportunity to be with you. And I'll turn it over to see if there's any questions or comments from the chat. Balaji?
As Dr. Catherine. Dr. Catherine, thank you so very much. Actually, when I was going through your biosketch, it had mentioned over 3,300 lectures in 3,300 sessions and over 40 countries. I know how you could easily pull those great numbers. Your presentation was very simple, easy to understand, and right at the point, very precise and very clear. Thank you for that. And really very happy that that you had accepted this webinar and you are part of this program. So the way that you had explained on the 4 phases of the definition of root cause analysis is a comprehensive systematic analysis to identify the causes, the 4 steps in it, the pictures that you showed, defense barriers, care delivery problems, contributing factors in the organizational culture, where you had explained about just culture, where you have explained about the 6 M's and 4 P's that we have it for manufacturing industries and for service industries. Very precise session. Thank you for that. I'm sure like we have around 300 participants, I could see in the Zoom call that they had participated. I'm sure it would be really helpful and insightful for them. Before moving on to the questions from the chat box, I have a question personally to ask you. When we are doing a root cause analysis, when we form a team, as you had mentioned that we should have a doctor and a kind of a frontline staff, a few members better, because they are the one who can easily come up with the issue list, because they know the problems actually they are facing it. And we should have a strategist, and we should have someone from the medical leadership or a CEO. But when we do a root cause analysis, there's always an emotional quotient in it. Because though the intent is not to blame anybody, though the intent is to understand the system and process failures and to do it. So how do we overcome this emotional quotient when we do root cause analysis? Because it invariably turns that, we are blaming some department or we are blaming some people. So how to communicate that effectively to the team members?
Great. Thanks, Balaji, and thanks for your comments. This is one of the biggest challenges. In fact, we could do a whole hour of how you run an effective root cause analysis meeting, right? So a couple key things, just be respecting our time. I, number one, have a very structured agenda. So in an organization I used to work in, there was a booklet we got, and that okay, number one, we do this. Number two, we do this, introduce ourselves, define, the date, all these very specific things. What that did is it kind of made us kind of follow this structure got us a little bit away from some of our emotion. The other thing is you got to have an effective leader who has emotional intelligence, who's able to set the stage. And that can be done in a lot of ways. Someone who's just really personable. But I've seen a couple things. Number one, I mentioned, let's all talk to each other with first names. That really sets us, we're Balaji and Kathy. It's not, Dr. Leonhardt or CEO. It's, hey, we're going to have a conversation together. The other thing is really powerful if that leader says, okay, we're here, we're going to talk about this event. I just want to share, I am upset because this is making me remember I was actually involved in a Sentinel event several years ago. It was devastating for me. This brings back some of those emotions. I know many of us are really upset about this. I mean, right away, you're like, our leader also feels bad. And it kind of sets that stage. Having someone there that can control the emotions and I actually respect organizations that do not bring the people who are involved in the event into the room. You interview them separately. So it's just Kathy and the oncologist talking. So I bet that oncologist is devastated in our case study, but he's not brought in this room with, 10 people looking at him. So your core team may not be the folks who were involved in the event. Though you're upset, keep those people out unless they insist they want to come into the room and you have a process if they're emotionally able to do that. So it is challenging. There's a couple specific actions you can take, tactics you can take to help reduce that emotional stress. And always have professionals available, right? That if someone really needs it, they can go to a professional.
Thank you. I think that answered that question. We have one question from Mr. Ramesh Chintala, where he's been asking, shall we do a detailed root cause analysis for near misses?
So great question. If you go back to my slide that had the triangle, which was also kind of an iceberg image, the near misses may not need a full root cause analysis. Now, there are organizations that do that, and that's wonderful. Most organizations I know don't have the time or resources to do a root cause analysis on every safety event, right? We pick and choose, and there's some criteria around which, high frequency or high severity events, whether they're real or near misses, those you may want to do a full RCA. I can tell you my studying and I'm continuously learning when I look at concise analysis or common cause analysis. They use the same tools and approach. It's just a little less detailed, right? A little less intense. So if you've got a near miss that had a potential to have significant harm and is happening frequently around your organization, you may want to do that full RCA. You may also do one of those more concise analysis.
Okay. There's also another question from Mr. Manikandan Suraj. He's been asking, does implementation of root cause analysis only involve quality personnel or every supervisory personnel in clinic to be trained? What is the feasibility for the same?
So to make sure I understand, the question is, does everyone need to be trained in the details?
Yes.
No. So back to what I like when I see in an organization, when they have a core team. So they have, again, 6, 8 people who are specially trained. They attend our RCA workshop. They've read several textbooks. They've participated and maybe been mentored by someone who's experienced in conducting an RCA. And those people are the ones that have that extra special training. Others may attend a webinar like this and have a 1-hour understanding of what a root cause analysis is. I mean, how powerful if everyone across the organization could attend this type of webinar and just go, oh, that's what they're doing when they go and have a root cause. Because many of us are fearful, right? I was involved in an event. Oh my gosh, I'm going to be a part of that root cause analysis. What are they talking about there? So sharing so people know. But the skill set of being able to conduct the analysis, it really just needs to be a core team.
Core team. Thank you, Dr. Kathy. And we have one more question, which is a very important question. What is an optimum timeline for doing a root cause analysis?
So as a Joint Commission International Consultant, I will tell you what our standard says. It says 45 days. So you must get that root cause analysis up to the action plan. Now, we don't expect that the action plan has been implemented, all of the work done, and then 45 days, you've done all that action planning, that you've created that action plan by 45 days. Now, that's a guideline. Some people may do it sooner. I know organizations that boom, 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 right away, they get their root cause analysis done, because that's when you remember, right after the event.
Okay. The last person, not directly related root cause, but it sets a context for the root cause on setting the culture for patient safety. So one of our participants has asked, how should one conduct a survey on culture of patient safety, such as Manchester Patient Safety Framework?
Yeah, so great question. And also a Joint Commission standard is evaluating your culture around safety in your organization. There are different tools out there. There's different validated surveys. That's one of the things I recommend is you look to the literature, right? You don't need to recreate something. There are validated tools out there. One that I'm most familiar with, because I've worked with them, is AHRQ, ahrq.gov. They have a survey on patient safety culture, the SOP survey. And that is, again, through research, and they know that the questions are valid and accurate. And there's a benchmark. They have a comparative benchmark that you can compare yourself to other hospitals and healthcare facilities that have conducted the same survey. There are different ways of doing it. There are other tools. You can do it by interviews and focus groups with your staff. You don't have to do use one of those survey tools. But the important thing is not just that you measure it, what are you doing about it? So take that data and say, gosh, for example, our staff, 80% of our staff feel like they're uncomfortable reporting something because they feel like they're going to be disciplined if they just report something. You better work on that. So how do you share with your staff that it's okay to report? We want you to report, and maybe even sharing them, having them attend a webinar like this. This is why we want you to report, so we can improve our processes. Not that we're going to find bad staff. We want to work on improving our systems and processes to make it easy for you to do your work the right way and make it harder to make it harder to do the wrong thing. It's all about creating that environment for your staff. Go ahead.
Thank you, Dr. Kathy. I think thank you very much for answering all those questions patiently and pragmatically, I would say, because these are the real tips that the healthcare professional would be wanting to know to implement things effectively. Thank you so much for that. I also have to thank close to 300 plus participants who have joined this webinar and participating in the poll questions. We have had 2 poll questions during the session. Most of them participated in that, and they are still asking questions actually, so I could find their enthusiasm. Thank you for that. And so this is not going to end today. We are going to have a session tomorrow as well. So our tomorrow session is going to be on a very important topic. It's on infection control. Managing SUDs for infection prevention and control. The session is going to be moderated by Dr. Emuna, who's an infection control officer at Apollo Hospitals, Chennai, Maine. We are going to have 2 speakers, Dr. Leena Mendireta, she's an infection control head from Apollo Indraprastha Hospitals, New Delhi, and Dr. Shashank Devapur. He's a co-founder and CEO of Inflection Healthcare Services. So I request all the participants to log in for tomorrow's session also and get the benefit of the pre-conference webinars. The webinars are effective, not by the speaker, not by the moderator, not by the presentation, it's by the participants, how you can take things effectively. And even if you could implement whatever has been discussed, a 50% of it, we'll be very happy that yes, we have achieved its intent. Thank you very much for joining. And please do not forget to register for the 9th International Patient Safety Conference scheduled on 13th and 14th of this month at New Delhi. I can tell you the conference is going to be brilliant. We are having participation from Joint Commission, ISQA. We are having participation from NABH, all major healthcare organizations. We are having over 20 plus international speakers. It's a 2-day conference with a lot of paper presentation and awards. So please do join for the International Patient Safety Conference. Thank you very much. And thank you, Dr. Katie, once again. Thank you.
Namaste. Thank you.
Namaste. Namaste.